All right, so another nukes talk. This is another special topic. This is going to be a two-part talk on non-pet cancer imaging. So usually when you think cancer imaging, you immediately go right to thinking about pet. But I'm going to talk about at least two different exams that are used not infrequently, also for cancer imaging. So let's have a look. So there's always this crap, right? What scan is it? It's a luxury to be told what kind of scan that you're looking at. So just reviewing real fast how we decipher that. Remember, the first step is to decide whether or not bones are visible. So we're going to go down the no bones route. The next step is to sort of look whether or not you can see the heart or not. So in this case, we can. A way to remember this here is that two basic things where you can see the heart that don't have bones. One is sestamibi, obviously. That's done for heart imaging, so that one's obvious. MIBG is the other one, and if you don't care about kids and neuroblastoma, you don't have a heart. So, although that's not always the case. Another way to remember that MIBG is the one that doesn't have the kidneys is that typically, we're talking about like an adrenal thing, right? So if you see kidneys, then that's going to make it hard for you to tell what's kidney and what's adrenal. So you wouldn't want a test that had kidneys visible. So that's sort of one route. Now, if you've looked at this, then you may notice that there's two ways sort of to get to MIBG down here. So sometimes you do have a heart, sometimes you don't have a heart. So in a situation where you don't have a heart, cardiac uptake is variable with MIBG. That's the point. And so the other one is whether or not you're going to be dealing with thyroid or iodine. Thyroid scan, and the liver is the trick. Now, you can see a liver sometimes in thyroid also, but that's a very special situation where you've been ablated. You've had about 131 ablation treatment. All right, so just a quick refresher on some pathology here. We'll do a quick this versus that. This is from PED. So we've got masses that are sort of in the general vicinity of the kidney and the adrenal. This one here's got an obvious claw sign, and it is a solid tumor. This one here, not definitely showing it coming out of the kidney. Remember, if you're not shown that it's coming out of the kidney, then it's not coming out of the kidney. If they want you to know that it's coming out of the kidney, they're going to show you a claw sign. It's not real life. You're not going to be able to scroll up and down. That's a gamesmanship tactic. Don't try to say, oh, I don't know, I can see the kidney, maybe it is coming out of the kidney. If they wanted you to know, then they would show it to you. The other thing is that little pieces of calcification in there. This looks like maybe this is wrapping around a vessel. So those are all sort of neuroblastoma features as well. So reviewing some more trivia here. Remember the age difference. Neuroblastoma tends to occur in younger kids. You can be born with a neuroblastoma. You cannot be born with a Wilms tumor. Neuroblastoma tends to calcify more often, and Wilms tends to invade into vessels like an RCC likes to invade into the renal vein. Wilms sort of does that stuff too, whereas neuroblastoma tends to wrap around vessels, more like a lymphoma. All right, and go back to that just for give you a chance to read it. It's basically saying the same thing that I said. All right, moving on, and this is a classic look. Okay, so we've got MR imaging here. We've got these big fucking bilateral masses that are sort of like in the periorbital region, and this is classic neuroblastoma METs. The raccoon eyes. This is another neuroblastoma image, same patient, again showing wrapping around vessels. Do see kidney, but there's not a clear claw sign, right? You want to see that? want to see, if you want to call that a Wilms, you want to see the claw come around like that, and we're not being shown that, so that's not a Wilms tumor. All right, so let's run through some trivia here. Neuroblastomas can occur anywhere along the sympathetic chain, which is basically from the neck all the way down to the pelvis. The most common location is the adrenal. That's where you usually see it. What about thoracic tumors? Who are they seen more commonly in? They are actually, so that's actually more common in infants as opposed to slightly older kids. And they tend to have a better prognosis. They relapse less relative to abdominal stuff. When you think about head and neck Mets, you think about the raccoon eyes, the orbits, not like intraaxial Mets, extraaxial stuff, dura, bones. That's more neuroblastoma style. So if I was going to show you a single plain film image that was a bone, MSK bone plain film image, and it was, I wanted you to say neuroblastoma, what I show you? Lucent metaphyseal bands. Remember, there's a big differential for that. Leukemia is in that differential. But if you're going to think about metastatic disease and it's a kid, think neuroblastoma. So there's a classic, they could give this to you. This would be useful to know for like in the question header. 2% of the time, you can get this immune-mediated physical exam finding, which is this dancing eyes and feet, where you've got this, an antibody, whatever, interacting there, making the eyes bounce all around. You can YouTube that if you want to see what that looks like. Is that bad? Actually, it's good. It's associated with favorable disease that's well differentiated. And then lastly, what is this stage 4S? Remember, this is the good one. Even though you think stage 4, you think bad, but the S is for special, and special in this case is good. So skin, liver, and bone marrow. And the bone marrow involvement should be less than 10%. That's what, and in fact, because it's less than 10%, it should not show up on an MIBG exam. So bone marrow should be negative on MIBG, even with stage 4S. It's a piece of trivia. And it is associated with a good outcome. But yeah, so that might be too much depth. You can get yourself into trouble. Forget that. That's like more practical knowledge. For multiple choice, skin, liver, bone marrow. Okay, the fact that the bone marrow negative on MIBG thing is gonna, I don't want to cause confusion. So skin, liver, bone marrow, stage 4S. If you want to be really smart, you don't want a lot of bone marrow involvement. It should be less than 10%. Okay, so what is the test of choice to identify metastatic sites? So you may have guessed it based on the fact that we're doing an MIBG talk, that is MIBG. It's around 90% sensitive and specific, and it's pretty damn good. So why would you use CT or MR? They have their utility as well, but it's usually more for like how big is a tumor, is there regional disease, extent, miscellaneous risk factors, etc., stuff like that. So, all right, here's a question for you. MIBG, is that imaging what part of the adrenal normally? The cortex, the medulla, both? It's actually the medulla only, and we'll talk about why that is. At diagnosis for neuroblastoma, Mets are most commonly where? They're going to have them one spot. Where are they going to be? If you were just going to guess. The answer is marrow, and actually part of the workup is they do marrow biopsies on all these kids at diagnosis. All right, so how does MIBG work? So go back here. So you've got, it's a norepinephrine analog. Now normally, your norepinephrine gets taken up through an active transport system. There's a small component that's actually passive diffusion, but let's just say the vast majority of it is a active transport. What does active transport mean? That means that there's ATP, and in this particular transporter is a symporter, which it has sodium and norepinephrine that come through also. So these uptake system is found at the sympathetic neuronal synapse. And it's this, like I said, sodium facilitated uptake, active transport, and this will actually uptake both norepinephrine and dopamine. The vast majority, like 90% of neuroblastoma tumors express this receptor and therefore are MIBG active. All right, there we go. So MIBG coming up. Oops. Yep, that's right. Boom, coming in there the same way. So, here's a piece of trivia also. The uptake is proportional to the number of storage granules within the tissue. So, more storage granules, hotter uptake. Less storage granules, less hot uptake. All right, so let's do a comparison real fast here between the 131 and the 123 versions of MIBG. So you can tag, so you have the physiologic part of nuclear medicine. So it's all nuclear medicine sort of works like this, right? You have something that's mimicking physiology. In this case, MIBG is mimicking norepinephrine. And then you have to have a part that's tagged to it that you can image. And so iodine 123 or iodine 131 are typically tagged to the MIBG, and that's the part that's giving up your gamma, so it lets you image it with the gamma camera, which that's what's letting you do that. So historically, 131 was used, and because it was cheaper, etc. But it's really not optimal for a couple of reasons. One, as you hopefully know, or if you don't, I will tell you, 131 is a high energy photon. And because of that, it's very inefficient capturing it. You have to use the thick plates, and that messes with your spatial resolution. There's also dose issues because this is also used for treatment, so it's also a beta emitter, and it's got a long half-life, 8 days relative to the 13 hours of 123, and you have to wait basically until it cools off well enough so that you can image it. So the dose is that you can actually give with 123 is way higher. You can give like 7 times more 123 and not hurt the patient. So the photon flux is way better. Your imaging is way better. You don't have to wait the scan. You have to wait the scan with 131 so that you can improve your target to background ratio. You don't have to do that with 123. So basically, you can use thinner plates. You don't have to worry about as much septal penetration because it's medium energy as opposed to high energy. Therefore, you get better spatial resolution. The dose is not as big of an issue, so you can give more of it, which gives you more photons to image. It's a shorter half-life, therefore it's washing out of the system quicker, and you can obtain the scan earlier. So 123 is the way to go, but you can use 131. All right, so this is a typical look. The heart is actually less commonly seen. Remember I said you could or could not see the heart. If you're going to remember one, maybe remember that it's actually seen less than it is seen. So you do have some nasal mucosa and salivary gland uptake. May or may not see the heart. You will see the liver for sure, and bladder. Now, morphologically, you may see a normal adrenal on SPECT. Morphologically, normal should look like a Y, right, or V. But even then, on SPECT, it's usually very faintly seen, like 30% of the time with 123, and even more rarely with 131, because remember 131 has less photon flux because you can't give as much dose. So how do you know it's not a PHIO? Like you're like, oh fuck, there's uptake in the adrenals. What do I do with that? Well, most PHIOs would have uptake greater than the liver, like 80% of the time. So you can use the liver as an internal control. In addition to that, there's going to be a mass there. They must always have a lesion, so like you correlate with CT or MRI. So bottom line is, if you see faint, morphologically normal, i.e. looks like an adrenal gland, it's V-shaped or Y-shaped, on SPECT, less than liver, without a corresponding mass lesion, it's normal. But I don't expect that they would do that on the exam, because that would be like some major fuckery, but that's like a practical real life thing. Now, what they may do, and I'll talk about this some more later, is bones. You should never see bones with MIBG. Never. That's not normal. Not normal to see bones, okay? No bones. Remember, that was step 1. No bones. Okay, so what about this guy? That thing. I wonder if he forgot something. So what we've got here is inadequate blockage of the thyroid. Thyroid blockage? You didn't... What does that mean? Remember, we're giving iodine 123 or 131 as a tracer agent. So that has the potential to, especially if you're giving 131, potential to injure the thyroid gland. So you give a blocking agent, it's high potassium or high iodine agent, that you get this massive dose of iodine, and that makes the thyroid not take anything up after that. So it's like, I was really thirsty, or I was really hungry, and then I gorged myself, and then I wasn't hungry for a while. So think about it like that. Lugol's solution is this high iodine solution. You'll often hear that it called that, okay? Or SSKI, supersaturated potassium iodine. You could possibly see that written. That's what that means. Supersaturated potassium iodine, SSKI. So typically it's done for 3 days, starting the day before the exam, although you can get away with a single dose at the time if you're using 123. If you're giving 131, you'll have to do it for longer, 1 day before and 6 days after, because remember, this has a longer half-life than 123. So 3 and 7 is how I would remember it, and the longer one for the longer half-life. And if you don't block it, then you'll see the thyroid. Otherwise, you should not see the thyroid, because you assume that they've had appropriate prep and blockade. All right, what about this guy here? What about that? Is that METs? So brown fat's not just a pet thing. It's actually the most common variant in the biodistribution of MIBG. Why, you might ask? Because there's actually sympathetic innervation of the brown fat. And if there's sympathetic innervation, that means there's norepinephrine uptake. All right, what about this guy? Remember, no bones. Oh, bad bones. So 3 things you should not see bones in: MIBG, iodine scans, octreotide. Okay, that means if you see it, it's METs. That's what that means. It means he has diffuse osseous METs. It's like a super scan, basically. It's the MIBG equivalent of a super scan. No bones. No bones. Notice this guy, really faint heart uptake, liver. All right. So some trivia here. This is highly testable. There is a gigantic list of medications that interfere with MIBG. Massive, okay? I went through it. It would be impossible to memorize them all. These are the ones that I would know, and I'm going to try to give you a way to remember it. So, calcium channel blockers, labetalol, this guy here, which is in cold medicine. They may tell you that the patient is on cold medicine. Phenylephrine, tricyclic antidepressants, psych meds, and cocaine. So kids with neuroblastoma don't need TLC or cocaine. So TLC, tricyclic antidepressants, labetalol, and calcium channel blockers. Don't fall into the trick of other beta blockers. Labetalol supposedly is the only one that's bad. The rest of them are okay. But yeah, calcium channel blockers, labetalol, tricyclic antidepressants, risperidol, this guy, phenylephrine, cocaine. So what happens if you don't? Or what happens if they're on these medications and you and you don't know that. What does that look like? You get a bunch of skin uptake. It looks like a bunch of soft tissue uptake because basically there's blockade at the actual norepinephrine receptors, and so the tracer just is like floating around in the skin. Okay, so when you do SPECT for MIBG, when do you do it? And what I mean by that is, when do you stick them in the camera relative to the time after you've given them the dose? So typically this is done around 24 hours. Now you can wait until 48 hours for problem solving to get an improved background ratio. All right, how do you excrete MIBG? So if you do you breathe it out? Do you pee it out? Do you poop it out? Do you sweat it out? Or you just sort of wait for a physical breakdown to happen? So if you remember, the bladder is visible on these MIBG scans, so it's almost all of it is excreted via the kidneys. Now, speaking of that, what is the critical organ? So for MIBG studies, you'll see bladder or liver typically listed as a critical organ. However, there is a trick. If the thyroid is not blocked, the thyroid is actually the critical organ. Now, what is a critical organ? The critical organ is the organ that will reach its legally defined maximum dose first. It's not the same as a target organ, which is like where you're trying to actually stick the tracer. The critical organ is just the one that gets the hottest, the firstest. So other than neuroblastoma, are there any other tumors you can image MIBG with? So basically any catecholamine-producing tumor, so VOs, paragangliomas, carcinoid tumors. All right, so that's it for part 1, and we shall continue with part 2.